Okay. Yes. So good evening, everyone, and I welcome you all to this particular YouTube session on the clinical-based questions on cardiology. So I am myself Dr. Rajesh Guba. I teach general medicine in Arise Medical Academy. So in order to see that you should not face any difficulties regarding the clinical-based questions in your upcoming FMGE exam, we at Arise Medical Academy have come up this particular special sessions wherein we will be discussing only clinical based questions in this particular sessions. Okay. Yes, Santosh, good evening, and as well as Sai Tarni, good evening, and good evening everyone. Okay, now let me start with the clinical based questions in the cardiology. So always I tell you one important point. Whenever you are reading the clinical based questions, you have to assume yourself that patient is directly presenting to you. You are the doctor in the emergency medicine department, or you are the doctor in the outpatient department. The patient is directly presenting to you and you are listening the history from the patient. That is how you have to assume whenever you are reading the clinical based questions. And utmost concentration is very important whenever you are reading the clinical based questions. Now it is mainly because of the deviation of concentration when reading the clinical based questions that makes the individual to have the questions to be read repeatedly. Because of the question being read repeatedly, there is a lot of time consumption and the student feels that the question is very difficult. That is not actually. So if you read the question with utmost concentration from the beginning itself, then you will understand the question or the clinical scenario in one reading, then you can crack the question in the first reading itself. Okay, right. Now with this basic background, we will just go ahead with the clinical based questions. Okay. So you see here, the question is like completely very scary, right? Very scary question. The question is lengthy and options are also lengthy. So what do we feel? We feel that the question is very difficult question. But as such, the question is not at all difficult question. I will make you very simple how to make out these particular clinical based questions in a very simple manner. All right. Okay. Let us start with the discussion. So we have a 21-year-old sommelier at a well-known restaurant. His primary hobby is competitive bicycle racing, and he has a 150-kilometer race. Right? He has a 150-kilometer race coming up the next weekend. Right? Coming up next weekend, for which he has been training for the last 6 months. But see, he has to go for 150-kilometer racing on a bicycle. So what the race coordinators have done, the race coordinators require every competitor to complete a comprehensive cardiovascular assessment prior to the competing, and thus he comes to visit your clinic. On your assessment, you note a resting heart rate of 45 beats per minute with occasional pause of up to 2 seconds. His blood pressure is 108 by 172 millimeters of mercury, and he feels well and reports no syncopal or pre-syncopal episodes at rest or during the exercise. From the bradycardia, you note no other abnormalities on his examination. His ECG shows the sinus rhythm with a PR interval of 128 milliseconds. The QRS duration is 80 milliseconds and occasional pauses as long as 2.2 seconds. Which of the following would be appropriate advice to Mr. Hedrick? Perform electrophysiological evaluation for consideration of a pacemaker. He should not compete in upcoming race due to concern for bradycardia. No further follow-up is needed. Good luck with his race. Obtain 48-hour Holter monitor tracing. He should undergo treadmill stress ECG to determine the presence of the chronotropic competence. So what you want to advise to Mr. Hendrick? Yes, Sai Tarni, why do you want to do no further follow-up? The heart rate is 45, right? The heart rate of the individual is 45. How can you just leave the patient like that without any follow-up? Any particular reason you have answered C? Yes, any one of you? So what is this question basically about? This question is basically about an athlete wanted to participate in bicycle racing, right? And his race coordinators have asked him for the cardiology evaluation, and the heart rate has been found to be 45 beats per minute. PR interval normal, the QRS complex is normal, and occasional pause as long as 2.2 seconds is there in the ECG. So what will you tell to the patient? Okay, very good, Sai Tarani. So the answer is no further follow-up is needed and good luck with the race. Okay, now why? See, the heart rate of 45 beats per minute, it can be expected in athletic patients. It is a normal phenomenon in athletes. Why? Because in athletes, there is high vagal tone. Right? Because in athletes, there is increased vagal tone. All right. So because of this increased vagal tone, the heart rate can be 45 beats per minute. That is expected, very much expected. And now, if you are worrying about any other phenomena, the other point is that there is no syncopal and there is no pre-syncopal episodes at rest or even during exercise. During exercise also, there is no syncopal attacks or there is no pre-syncopal episodes. That means, what does it tell you? It tells you that the individual is completely asymptomatic. Can anyone tell me what will be the clinical features of your pre-syncopal episodes? Yes. What are the features of the pre-syncopal episodes? Any one of you? So, the clinical features of the pre-syncopal episodes, it is nothing but giddiness. So this particular giddiness, it is not present in this individual. Right, this particular giddiness, it is not present in this individual. Okay, so that is the reason why, remember. And what about this sinus pauses? Remember, right, remember the sinus pauses, if it is less than 3 seconds, right, no need to worry, right, no need to worry if the sinus pauses is less than 3 seconds. Now, what is the sinus pause in this patient? The sinus pause in this patient is 2.2 seconds. So it is not at all a scenario where you need to worry. Okay, so no further follow-up is needed, and you just wish him a very good luck with the race. So he is an absolutely a normal individual. Electrophysiological evaluation not required. Because bradycardia is there, he should not compete is a wrong statement. Obtain 48-hour Holter monitoring? No. He should undergo treadmill stress ECG to determine the presence of chronotropic incompetence? That is also a wrong statement. So he is an absolutely normal patient. Wish him good luck and let him participate in the race. Okay, next. Now, yes, have you understood this explanation of this question? Just give me a thumbs up or tell me yes whether you have understood this or not. Okay, very good. Now, let me just go ahead with the next question. Yes, this is another very important, the clinical based question. An 87-year-old man with the history of Right. An 87-year-old man with a history of well-treated hypertension and aortic stenosis has become symptomatic from his aortic stenosis over the last 2 months. Right, over the last 2 months, he has been symptomatic for his aortic stenosis. And yesterday, he underwent surgical aortic valve replacement. Right, yesterday he underwent surgical aortic valve replacement with the bioprosthetic valve of 25 millimeters valve with excellent intraoperative results. He was rapidly weaned from the cardiopulmonary bypass and extubated with 24 hours. Right, extubated within 24 hours. As per the surgical protocol, he had a temporary epicardial pacing wires placed on the ventricular surface and has been pacing at 90 beats per minute. So with temporary pacing, what is the heart rate? 90 beats per minute. And on rounds this morning, you briefly paused his ventricular pacing. That means you have stopped the ventricular pacing to check the underlying rhythm. You noted an atrial rate of 80 beats per minute and ventricular rate of 32 beats per minute with a wide QRS complex. Right, with a wide QRS complex. And there is no relationship between the P wave and QRS complexes. Right, there is no relation between the P waves and QRS complexes. And this patient's ventricular bradycardia is most likely due to which of the following reasons? Development of a systemic disease such as sarcoidosis or Lyme disease causing AV nodal dysfunction, endocarditis of new aortic bioprocesses causing AV node block, SA nodal disease, slowed AV nodal recovery after overdrive pacing, surgical injury to the AV node. Right, so very good, Sai Tarni. So the answer is the surgical injury to the AV node, right? Okay, so why are you expecting the surgical injury to the AV node? Let me explain what is this temporary epicardial pacing and all. What is the story? I will tell you. So this patient is suffering with the aortic stenosis and he is symptomatic, right? He is having symptomatic aortic stenosis. Now, what are the clinical features of symptomatic aortic stenosis? The clinical features of the symptomatic aortic stenosis, it includes angina, syncopal attack, and as well as dyspnea. Right, angina, syncopal attack, and as well as dyspnea. These are the clinical features of aortic stenosis. Now, if there is clinical features in aortic stenosis, definitely it's a definite indication for aortic valve replacement. Right, it is a definite indication for aortic valve replacement if there is presence of the clinical features or if there is presence of the symptoms. Okay. Now, the point is that whenever you are doing aortic valve replacement, where is the surgery you will do at this point? You will cut off these valves, you will remove these valves, and you will keep a prosthetic aortic valve. Right? You will keep a prosthetic aortic valve. Now, whenever you are keeping a prosthetic aortic valve, there is a very high chance that this prosthetic aortic valve can compress this AV node. You see, this is your AV node. Right? This is your AV node. So there is a very high chance that this AV node can be compressed. There is a very high chance that this particular AV node can be compressed. So what is that? Now why? Okay, that is the complication that has developed in our patient. How can you tell that? right? How can you tell that this patient has a surgical injury to the AV node? How can I tell this is because whenever the patient is on temporary epicardial pacing, the heart rate is maintained 90 beats per minute. But whenever you pause his ventricular pacing, what is happening? The ventricular rate is falling to 32 beats per minute. Right? The ventricular rate, it is falling to 32 beats per minute. So thereby, what will you make out now? Whenever, that means the patient is completely dependent on ventricular pacemaker, temporary pacemaker. How can you tell that? Why? Because if the pacemaker is removed, the heart rate is becoming around 32 beats per minute. Right? The heart rate is becoming around 32 beats per minute. So that is the reason why you have to expect that there is an AV nodal injury. If AV node is gone, definitely ventricular rate will be reduced. Right? If AV node is damaged, definitely ventricular rate is reduced. Okay, so this individual is having ventricular bradycardia due to surgical injury to the AV node. Why surgical injury to the AV node? Why? Because your AV node is adjacent to your aortic valve. So whenever you are doing the prosthetic aortic valve placement, there is a very high chance of the AV nodal blockade. So whenever there is an AV nodal blockade, then you will have bradycardia. So what is the treatment now? So if there is surgical injury to the AV nodal blockade, what is the treatment? So how do you treat this patient now? So how do you treat this patient now? Yes, Sai Tarni, can you tell me how do you treat this patient? So how is this patient to be treated now? So this patient has to be placed on the permanent pacemaker. Not beta blockers. Already ventricular rate is low. Why will you give beta blockers again? Already the heart rate is around 32 beats per minute. And if you give beta blockers, that will further cause bradycardia and make the individual to land up in cardiac arrest. Right? So please don't give beta blockers when the ventricular rate is 32 beats per minute. So you have to place the patient on the permanent pacemaker. Right? So the answer is permanent pacemaker. Now, so this is iatrogenic AV nodal injury. Iatrogenic means surgically induced AV nodal injury. Okay. Next. Now we will move on to the next clinical question. Yes. Mrs. Helwig, she is a 25-year-old woman with systemic lupus erythematosus. She is complicated by nephropathy, hemolytic anemia, and pleuritis. Her disease is well controlled on therapy. What is the treatment you will give for SLE? The treatment what we give for SLE is steroids. She recently discovered that she is pregnant and presents today for prenatal counseling. She specifically is concerned about the effect of her autoimmune disease that may have on the infant. You tell her that the most common cardiac complication in children born to mothers with SLE is AV block, coronary artery disease, dilated cardiomyopathy, pulmonary hypertension with right ventricular failure, Liebman-Sachs endocarditis. Yes, Shinoy, Liebman-Sachs endocarditis. Okay. Any other answer? Okay, Balaraman says D, pulmonary hypertension with RV failure. Okay, so now what is the worry in the children is children born to mothers with SLE will develop what is called neonatal lupus. Right, will develop what is called neonatal lupus. And what is the cardiovascular complication of neonatal lupus? So if you take the cardiovascular complication of the neonatal lupus, that includes the complete heart block, that is third degree AV block. That is what is the expected complication you will see in case of the neonatal lupus. So the answer is AV block. The answer is the AV block in this patient. Okay. Now the question is not about what will be the cardiac manifestation in 25-year-old man or old women. The question is about what will be the cardiovascular manifestations in the children born to mothers with SLE. So in children born to mothers with SLE, they will develop neonatal lupus. And in them, the cardiac manifestations will be in the form of the complete heart block, which is nothing but your third degree AV block, which is nothing but your third degree AV block. Now, the another point is you take in adults. You take in adults. What will be the cardiovascular manifestations in adults in SLE? So the cardiac complications in adults with SLE, they develop what is called pancarditis. That means pericarditis, myocarditis, and endocarditis. Right, pericarditis, myocarditis, and endocarditis. So pericarditis, they present with chest pain. Myocarditis, they present with heart failure. Right, endocarditis, they present with valvular pathologies. Right, they present with the valvular pathologies. Right, that is nothing but Liebman-Sachs endocarditis. And if you take the treatment also, right, if you take the treatment in case of pericarditis and as well as myocarditis, you need to give steroids. Right, you need to give steroids in pericarditis and as well as myocarditis. Whereas in endocarditis, you need to do valvuloplasty. Right, you need to do valvuloplasty. So that is what is the cardiac manifestations in SLE in adults. But whereas in children, they will develop what is called neonatal lupus. In children born to mothers with SLE, they are born with neonatal lupus, and the cardiac manifestations will be in the form of the AV block, right? Complete AV block. That is nothing but your complete heart block. Okay, and they will also present with the coronary artery disease. Which one? Who? Adults. Right? Adults with SLE, they can also present with the coronary artery disease. Okay, so why? Because of inflammation of the vessels, that is vasculitis, that is due to vasculitis. Okay, so that completes the discussion of SLE and cardiac manifestations in adults and as well as even in children, right? In adults and as well as in children as well. Okay, Right. Okay, so we have a 19-year-old long distance runner who finished in the top 10 of the local marathon last year. And he presents for cardiac evaluation after his primary care physician ordered a Holter monitor for screening purposes. On his Holter report, several episodes of second degree Mobitz type 1 AV block were noted, all occurring during sleep. The patient reports no symptoms but thinks he may have a grandfather who had a pacemaker implanted at the advanced age. Right? No symptoms as such, but the history is that he had a grandfather who required pacemaker at an advanced age. What is the most appropriate next step in this patient? Exercise treadmill stress test, invasive electrophysiology study, reassurance, refer for pacemaker implantation, serologic testing including thyroid stimulating hormone levels. Yeah, what do you want to do in this patient? Yes, what you want to do in this patient? Very good. Very good, Rakshita, Narayan, and as well as Faizan. So just reassurance, that's all. Just reassurance. Why? Why? Because he's a long-standing runner. That means he is an athlete. Right? He is an athlete. Okay. Now, in athletes, right? In athletes, remember, there will be increased vagal tone. Right? There will be increased vagal tone. Now, this second degree AV block, Mobitz type 1, in which part of the Holter report you have noted? It is occurring during sleep. Right? It is occurring during sleep. And the patient reports no symptoms. He is asymptomatic. But during sleep, you found that there is second degree AV block of Mobitz type 1. Now, tell me a point here. In sleep or during sleep, what will happen to the vagal tone? What will happen to the vagal tone? Anyone? In sleep, what will happen to the vagal tone? So during sleep, remember, the vagal tone of the individual will be increased. Right? During sleep, remember, the vagal tone of the individual is increased. And upon that, he is an athlete. So in athletes, vagal tone will definitely be increased. So because of this reason, the individual is having Mobitz type 1 second degree AV block. Right? Because of this reason, there is excessive increase in the vagal tone, due to which he is presenting with Mobitz type 1 AV block. So please don't do anything. Don't do any treadmill. Don't do any catheter ablation, or don't do any electrophysiological studies. Just give an appropriate reassurance. That's all. Right? So just give an appropriate reassurance to the patient. That will be enough. So the answer is reassurance. Okay, no pacemaker implantation, no electrophysiology studies, right? No thyroid stimulating hormone levels, nothing. So just reassure the patient that you are absolutely normal, not to worry at all, right? And you can go ahead with your athletic practice. Okay. Right. Now we will move on to the next question. Yes. Right. So this is the question related to your the WPW syndrome. Right. This is the question related to your WPW syndrome. Now, what is that? Let me tell you. Mrs. Millsap, she is an 18-year-old high school volleyball star. Right. She's a volleyball player and she is a champion in volleyball player. And she also has the sports scholarship to the local university. When she played in the local university, she won the sports scholarship as well. Now, as part of her admission process, she is required to undergo a full medical assessment prior to taking any college sports. Right? Prior to taking any college sports, she has to undergo a full medical assessment. Okay, fine. You have done the physical examination, right? Reveals no abnormalities, although she reports rare episodes of palpitations, rare episodes of lightheadedness, and right, and ECG reveals the PR interval of 0.06 milliseconds, QRS duration 140 milliseconds, and there is slurred upstroke or delta wave in the initial part of the QRS complex. You correctly diagnosed this as Wolff-Parkinson-White syndrome. Which of the following finding is reassuring that Mrs. Millsap will suffer no ill effects or need catheter ablation due to this abnormality? So I will summarize the question for you. The question is little confusing, but I will summarize the question to you. We have an 18-year-old girl. She's a volleyball player and she wanted to undergo some college sports. What the sports coordinator said, please get a medical assessment and then participate in the college sports. Then she said, fine. She came to you, you have examined her, you found no abnormality. But she says to you that, doctor, rarely I feel the episodes of palpitations and rarely I feel the lightheadedness. Then you were a little worried about it and you have asked her to take an ECG. And you got an ECG done, the PR interval was shortened, wide QRS complex is there, and slurred upstroke or delta wave is there. By seeing the ECG, TK, you said to Millsap that you are suffering with WPW syndrome, Wolff-Parkinson's-White syndrome. Now, Millsap is asking you, right? Millsap is asking you, doctor, now what should I do? Can I participate in the sports? Right? If I participate in the sports, do I suffer with any ill effects? Do I suffer any ill effects? Now tell me, again she's asking that based on which criteria, right? Based on which criteria you will assure me that there will be no ill effects, and based on which criteria you will assure me that there is no need for catheter ablation. Based on what criteria you will assure me? That is the question in this patient. Options: ability to increase the heart rate to 185 beats per minute on exercise treadmill test. Electrophysiology study demonstrated that accessory pathway has both antegrade and retrograde conduction properties. Electrophysiology study demonstrating that accessory pathway is located in the posturoseptal region. Exercise treadmill study demonstrating disappearance of the delta wave and wide QRS complex at a heart rate of 120 beats per minute. Holter monitoring demonstrating occasional runs of atrial fibrillation. Now, based on the 5 options given to you, based on which option you will tell to Mrs. Millsap that Nothing will happen to you. You will not have any ill effect. You don't require catheter ablation, based on which you will assure her. Very good. So, very good. So, Mohammad Faizan has answered and Sai Taruni has also answered. The answer is D. Exercise treadmill study demonstrating disappearance of the delta wave and wide QRS complex. Both of them, they get disappeared at a rate of 120 beats per minute. That is what the option which tells you that she will not have any ill effect. She doesn't require catheter ablation. Sir, what is this? We are not understanding anything, right? I will tell you. I will teach you in a very simpler manner. You take WPW syndrome. What is WPW syndrome? It is a pre-excitation syndrome. Right? It is a pre-excitation syndrome. You have an accessory pathway. Right? You have an accessory pathway in this patient. So normally you take the SA node and you take the AV node. You have 3 internodal fibers. Right? You have 3 internodal fibers: anterior, middle, and posterior internodal fibers. Right? Anterior, middle, and posterior internodal fibers. Okay. Now, apart from this anterior, middle, and posterior internodal fibers, you also have an accessory pathway connecting atria to the ventricle. Right? Connecting atria to the ventricle, you also have an accessory pathway. That is the reason why there is a pre-excitation. Now, because of the presence of this accessory pathway, right? Because of the presence of this particular accessory pathway, you will have a short PR interval. You take the normal PR interval. Right? If you notice the normal PR interval, how much is the normal PR interval? Normal PR interval, it is 0.1 to 0.21 seconds. Right? 0.12 to 0.21 seconds. That is the normal PR interval. That is a normal PR interval. But if you take the PR interval of our patient, that is 0.06. That means it is shortened. That means it is shortened. And because of the presence of the accessory pathway, the ventricle is receiving the impulse. Right? Ventricle is receiving the impulse via the accessory pathway. Impulse via the accessory pathway. Okay, so when ventricle is receiving the impulse via accessory pathway, there will be very slow velocity of conduction. Right? There will be very slow velocity of the conduction. Now, because there is very slow velocity of the conduction, these individuals, they will have wide QRS complex. Right? And not only that, they will have slurring of the QRS complex. And the slurring of the QRS complex, it is nothing but your delta wave. That is nothing but your delta wave. So this is the story of your WPW syndrome. Right? This is the story of your WPW syndrome. Now, this is the ECG. So you will have a short PR interval. You will have the presence of the delta wave. And you will have the presence of the wide QRS complex as well. Why is that? Because of the presence of this accessory pathway. Now, how will you assure Mrs. Millsap? How will you assure that is, if the individual with WPW syndrome, if he does the exercise, that is treadmill test, right? If he does the exercise, that is treadmill test, if the short PR interval disappears, right? If the short VR interval disappears, if wide QRS complex, right? If the wide QRS complex disappears, if short PR interval disappears, if the wide QRS complex disappears, remember, this tells that the individual does not require ablation, right? Does not require ablation, right? Ablation is not required in this patient. This individual is not seriously ill, right? This individual is not seriously ill. So the answer is exercise treadmill study demonstrating disappearance of the delta wave, right? Exercise treadmill study demonstrating disappearance of the delta wave and disappearance of the wide QRS complex at a heart rate of 120 beats per minute. That tells that the individual requires no need of catheter ablation and will suffer no ill effects, right? Will suffer no ill effects. So the answer is D. So to summarize this entire story, right? To summarize this entire story, in patients with WPW syndrome, on doing treadmill test, if there is disappearance of delta wave, then it is not a very serious condition in the patient. He does not require any ablation. That is what is the clinical scenario related to your WPW syndrome. Okay, next. Yes. Okay, last question, and then we will wind up this session after discussion of this question. We have a 85-year-old woman, right? 85-year-old woman with no prior cardiac history presents to the emergency department with 2 hours of palpitations. Blood pressure and saturation and heart rate, they are normal. Okay, only history is 2 hours of palpitations. Although you note an irregular rhythm on examination, ECG shows irregular, narrow QRS complex without discernible P wave at a rate of 75 beats per minute. Echocardiogram reveals no structural heart disease. Despite the normal heart rate, the patient is quite symptomatic with her atrial fibrillation and wants to pursue achievement of the sinus rhythm. All of the following interventions may be beneficial except so now what is the summary of this question? Summary is that the patient is in AF with controlled ventricular rate, right? Controlled ventricular rate. So when will you tell controlled ventricular rate? When the ventricular rate is less than 100 per minute, right? When the ventricular rate, right? If the ventricular rate is less than 100 per minute, then we consider that this patient is having the controlled ventricular rate. Okay. Now, what is the patient's concern? The patient's concern is that I am in AF. I wanted to pursue sinus rhythm. I don't want AF. That is what is the concern of the patient. Now, what is the question asked? All of the following interventions may be beneficial except adenosine intravenously, amiodarone intravenously, direct cardioversion, dofetilide orally, flecainide orally. Yes, what do you want to do to this patient? Okay, so right, so in atrial fibrillation, Three things are very, very important. The answer here is A. Adenosine intravenously should not be given. Right? What is adenosine? Adenosine, it is AV nodal blocking agent. So if you block the AV node, right? If you block the AV node in patients with atrial fibrillation, the individual will end up in complete heart block. Right? The individual will end up in the complete heart block. So that is the reason why, let me tell you, you should not give AV nodal blocking agent in patients with the atrial fibrillation. Complete AV nodal blocking agent. Okay. Amiodarone, yes, you have to give in order to make the individual to land up in normal sinus rhythm. Direct cardioversion can be done, but it is not the indication in this patient. But yes, if the patient is very much concerned, I want to get converted into sinus rhythm, yes, you can do direct cardioversion. Dofetilide and as well as flecainide. These are also antiarrhythmic drugs. AF can be converted into normal sinus rhythm even with your dofetilide and as well as flecainide. Right? Even with your dofetilide and as well as flecainide. Where do we give adenosine? We give adenosine in a clinical scenario of PSVT, paroxysmal supraventricular tachycardia, but not in case of the atrial fibrillation. So how do you manage a patient with the atrial fibrillation? There are three things which are required in the management of atrial fibrillation. That is rate control, rhythm control, and anticoagulation. Right? Rate control, rhythm control, and anticoagulation. Rate control, you will achieve this with beta blockers. Right? Or you will achieve this with calcium channel blockers. Rhythm control, you can give amiodarone, ibutylide, then flecainide. Right? Amiodarone, ibutylide, and as well as flecainide. So that is what is your rhythm control. And anticoagulation should be given if the CHA2 DS2 VAS scoring system, right? If the CHA2 DS2 VAS scoring system, if it is more than 1, then you need to give the anticoagulation. Okay. And this rhythm control can also be done by direct cardioversion. Right? This can also be done by direct current cardioversion. This can also be done by direct current cardioversion. So this is how you will treat a patient with the atrial fibrillation. Rate control, rhythm control, and as well as the anticoagulation. Right? In this patient, all these four, they are required for the rhythm control. Adenosine, you need to give in PSVT. And what is the dosage of adenosine PSVT? 6 mg. 6 mg intravenously should be given. For example, if the 6 mg of adenosine fails, then you need to give 12 mg of adenosine intravenously. Right? Then you need to give 12 mg of adenosine intravenously should be given. And even if this adenosine fails, then you have to give calcium channel blockers, that is verapamil should be given. Right? That is verapamil should be given. Okay. So this completes the discussion of a question related to your atrial fibrillation. How will you do the sinus rhythm? How will you make the individual to land up in sinus rhythm? Okay. So these are some of the clinical based questions for the today's session. So today's session was exclusively on cardiology. Right? It is exclusively on the cardiology. And tomorrow, again, more or less with the similar time, I will come up with some more clinical based questions in your general medicine. And let me tell you, in your upcoming FMGE exam, you have to expect a tough paper. We don't know if the paper is easy, you are happy and I am also happy. But if the paper is tough with this like clinical based questions, you should be completely prepared with that. So that is the reason why we at Arise Medical Academy are training you completely with all the sorts of clinical based questions in the general medicine. So please take the advantage of these free sessions and see that you comfortably crack your FMGE questions, right? So thank you very much, and I see you tomorrow again with some more clinical based questions. Good night and stay safe.